Good morning, everyone. Today, our CME was on laboratory diagnosis of septicemia. The first speaker is Dr. Vikramjit Datta. He is taking the topic when to suspect septicemia, the current guidelines. Dr. Vikramjit Datta is a clinical microbiologist, MD and DMB, with a postgraduate certificate course in hospital infection control, and he is currently working as an associate professor in the Department of Microbiology, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, with special interest in molecular microbiology and infection control. So I would now like to invite Dr. Vikram Datta to open the session on the topic when to suspect septicemia and current guidelines. Over to Dr. Vikramjit Datta.
Thank you, Dr. Shilpee. Warm greetings of the day, everyone. My name is Dr. Vikramjit Datta. I am an associate professor in the Department of Microbiology, Safdarjung Hospital. My presentation today will be on when to suspect septicemia and the current guidelines. In the presentation, I'll be talking of about the burden of sepsis, the definitions and the scoring systems, a slide about comparison among the scoring systems, and the need and indications of blood culture. So, talking of the burden of sepsis, according to the WHO global report on the epidemiology and burden of sepsis published in 2020, septicemia affects around 49 million individuals all around the world and approximately 11 million potentially avoidable deaths worldwide. Almost half of this septicemia cases worldwide occur in children in less than 5 years of age group. In 2018 alone, according to a study published in 2020, around 15% of all the neonatal deaths globally was due to septicemia. Almost half of globally, it is estimated that for every 1,000 women giving birth, 11 experience infection-related severe organ dysfunction or death. Now, here we have to keep in mind that similar to the trend in neonatal population, sepsis causing mortality and morbidity in women also are highest in the low and low middle income countries. Healthcare associated infections are an important cause of septicemia. As you can see that every 4 individuals in the hospital in a non-ICU setup and every second individual who is suffering from sepsis in an ICU setup is due to a hospital acquired infection. The overall adult mortality is around 27% due to sepsis, and the mortality in ICU related sepsis is around 42%. The aftermath of septicemia is also of great concern. As you can see that only half of the patients who suffer from sepsis, they can completely recover in their lifetime, while 1/3 die within a year, and half of these deaths are directly related to the episode of sepsis that the patient had suffered from in the past. 1/6 of these sepsis survivors, they have significant morbidity like functional limitations, for example, inability to bath or dress independently. Moreover, they also suffer from moderate to severe cognitive impairment, and there is also increased incidence of mental health disorders in such patients. An estimated of around 40% of sepsis patients have to be re-hospitalized within 90 days of discharge from the hospital. And this not only increases the burden on the individual, both mental and physical, but affects the healthcare system of the society as a whole. Now, there was a data published in the Journal of Infections in 2017 when they had collected data from the high-income countries, and it showed that the average hospital-wide cost of sepsis is incurred around more than $32,000 per patient. In the recent years, the alarming thing that has come up is that this trend is increasing over the years. Around 276 patients per 100,000 person years in the past decade has suffered from septicemia, and this represents a 46% total increase as compared to the overall time period. And the mortality is also higher in a hospital setup. And for a plethora of reasons known to all, we have seen that around 85% of the sepsis cases and the deaths related to sepsis occur in countries with low, middle, and middle socio-demographic indices, particularly in the sub-Saharan Africa and the Southeast Asian countries. So coming to the definitions and scoring systems that we have so far in septicemia, the first consensus definition of sepsis was based on systemic inflammatory response syndrome criteria, which came up in 1991, and this defined sepsis according to its severity into sepsis, severe sepsis, and septic shock. Now, although the term severe sepsis was defined as sepsis complicated by organ dysfunction, the sepsis 1 definition did not state what actually constituted organ dysfunction. However, it defined that septic shock as sepsis-induced hypotension which persisted even after adequate fluid resuscitation. So this was the search criteria that was given in the sepsis forum in 1991. It included 4 parameters, that is the body temperature, heart rate, respiratory rate, and white blood cell count. Now, any patient who suffered from 2 or more of this criteria was considered to be suffering from septicemia. Now, after the introduction of this criteria, there were many studies that were carried out in order to see in order to evaluate the feasibility of this criteria, in order for a quick clinical diagnosis. Now, there were many studies that were conducted. Here, I would like to mention a couple of studies. This was published in the New England Journal of Medicine, and this study showed that the presence of search criteria, they have conducted in a study in around 110,000 population, and they found out that around 12% of the patients were classified as having search negative sepsis. That is, they did not fulfill the systemic endemic syndrome criteria. That is, they were less than 2 or 4 of the parameters that the patient had been suffering from. Furthermore, there were other studies which showed the scenario on the other end of the spectrum, that search criteria were present in many hospitalized patients, including those who never developed any infection or never incurred adverse outcomes. So over the years, they saw that there were many loopholes in the system. So it took a decade to redefine the sepsis, and the major thing being they did not classify the organ dysfunction properly in the first consensus. So in 2001, the sepsis definition was subsequently revised, and a few changes were made. For example, severe sepsis came to be known as sepsis complicated by organ dysfunction, and it also provided an expanded list of symptoms, signs, and laboratory values that could indicate sepsis in the presence of infection. The forum also came up with a consensus that they should introduce a new criteria or a scoring system which would be able to help to diagnose clinically sepsis faster with more sensitivity and specificity. So they introduced what is known as the sequential organ failure assessment system, or the SOFA score, to define organ dysfunction properly. So this is how the SOFA score looks like. So they had included the following parameters: respiratory, renal, hepatic, hematological, neurological, and cardiovascular. So in the respiratory system, they have evaluated the partial pressure of oxygen and fraction of inspired oxygen. Creatinine and urine output was evaluated in the renal parameter. Bilirubin and platelet count were evaluated in hepatic and hematological parameters respectively. For the neurological parameter, the time tested and the age-old Glasgow Coma scale was used. And for the cardiovascular system, they had introduced the mean arterial pressure and the use and doses of catecholamine drugs, that is dopamine, dobutamine, epinephrine, and non-epinephrine. The scoring was done from a scale of 0 to 4, and any patient, and similar to the search criteria, any patient having satisfying 2 or more of the parameters were deemed as suffering from septicemia. Now, the SOFA score, when it was introduced, people took time gradually to incorporate into their systems, and then started comparing with the already prevalent search code, and they found out that nevertheless, even after almost 2 decades of trying to redefine and understand better the septicemia, there was little discernible difference between the sepsis 1 and sepsis 2 definitions, as it was found out that the signs, symptoms, and laboratory parameters that were used, that was again defined by sepsis 2 into, were considered to be too ambiguous. So the most recent definition was given in 2016 by a task force that was convened by national societies, including the Society of Critical Care Medicine and European Society of Intensive Care Medicine. So they defined sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, organ dysfunction, they had defined as an acute increase in the total SOFA score of 2 or more due to the infection. Now, gradually over a period of time, after they had started using the SOFA score and compared with the search score, the clinicians in the practice, they found out that there were certain difficulties in the SOFA scoring system, which made it impracticable for use in clinical practice. For example, the method of calculation in the SOFA score was a bit complex, and most of the times there was lack of requisite data from many patients for calculation of the score, and there were concerns of late identification because the main aim of the scoring system is to identify septicemia as early as possible so that the management can be started. So in SOFA 3, they had introduced a new, in sepsis 3, they had introduced a new system which is known as the QSOFA or the quick SOFA scoring, which was similar to the search scoring, and that they had only 3 parameters, that is the respiratory rate, the systolic blood pressure, and the altered mental state. So this became a kind of a very simplified version of SOFA and was considered as a kind of a rapid tool for evaluating patients with septicemia. Now, there were many studies that were conducted thereafter to see, to compare between the different systems, between the different scoring systems. Now, this is one study which was published in the Netherlands Journal of Medicine in 2018, where they had compared the different scoring systems. So they found out that SOFA, being simple and rapid, had a great specificity, but the main problem with this scoring system was the sensitivity. If you compare, when they compared the SOFA scoring system with search, they found that the sensitivity was better and comparable, and the specificity was also better in SOFA score than in search scoring, but QSOFA was still a very specific test. They had also done a combined scoring system, and they found out that the specificity increases to the highest when they combine QSOFA with a SOFA scoring, but still the problem remains with sensitivity. So the authors concluded that we should always be in the lookout for a more sensitive scoring system, as the earlier the treatment, as earlier the management is started, the better the positive outcome for the patient. So finally, in the last part of my lecture, I'll be telling about the need and indications of blood culture. So sepsis, as we know, is one of the most significant challenges in critical care, and hence early diagnosis is one of the most decisive factors in determining the patient outcome. A blood culture plays a pivotal role in sepsis management because once we get a positive blood culture, it establishes infectious etiology, and then we can continue with the antimicrobial susceptibility testing, thus paving the way for optimization of antimicrobial therapy. As we all know that effective and early antibiotic therapy is goes a long way in providing a positive outcome for the patient. So this is a graph which I have taken from a study by Kumar et al. In Critical Care Medicine 2006, which clearly indicates that the survival rate of the patient with septicemia is inversely proportional to the initiation of effective antibiotic therapy. So before I hand over the proceedings to my next speaker, Dr. Shilpee, who will be talking in details about the blood culture techniques, I would like to mention about the current CLSI guidelines for conditions in which blood culture should be obtained. So the conditions include febrile neutropenia, fever of unknown origin, suspected endovascular infections, including central line associated bloodstream infection, suspected infective endocarditis, any conditions we suspect where we can suspect septicemia, for example, cholangitis, complicated pneumonia, complicated skin and soft tissue infection, meningitis, and the rest, and unexplained leukocytosis. Thank you everyone for your time.
So moving to the next session, the topic of the next session is sample collection and transportation as per the CLSI guidelines. Now, let me introduce myself. I am Dr. Shilpee Kumar. I am currently working as Professor Microbiology at Bhawna Medical College and Safdarjung Hospital. I am also officer in charge of quality cell at VMMC. So let's begin the next session. Now, sample collection and transportation. I will be mainly focusing on the CLSI guidelines. What is the current recommendation of the CLSI guidelines? They have recently released second edition in 2022. So I'll be covering the pre-examination activity before the blood collection, what should be done, recommendation for collecting the blood specimen as per CLSI guideline 2022, labeling of the specimen, transportation criteria, and the rejection criteria. Now, what should be the pre-examination activity? So, since blood is a precious sample, it is an invasive procedure to collect the blood specimen. It is very important that first the patient should be assessed whether there is any indication for obtaining blood culture is there or not. That has already been covered by Dr. Dept in the first session, that when to suspect septicemia and what are the indications for obtaining the blood culture. So that was about the patient assessment. It should be done. Second is examination requisition. The clinician shall raise a request either in the paper form or in the electronic form. Both are acceptable, but the clinician shall raise a request and the laboratory people shall define the criteria, what all details is required in the patient PRF to do the blood culture. As per CLSI guidelines, they say these are the limited, there are certain limited information that is required, but you can customize as per your own setup. So the patient demographic detail is mandatory, along with the name of the examination, the collection site from where we have collected. It should be the part of the format TRF, and the name or you can trace the phlebotomist who has collected the specimen, when he has collected the specimen, date and time, and who has raised this request, the name of the clinician, so that you can inform or you can give suggestions to the clinician as per your report. Now, the third pre-examination activity is the collection requirement. Whosoever is collecting the blood, there has to be an SOP, and that person should be trained as per that SOP. So the number of the blood culture set to be collected as per the CLSI guidelines is 2 to 3 blood culture sets. One blood culture set means 2 bottles, one aerobic and one may be anaerobic. I'll be covering in detail. So at least 2 to 3 blood culture sets should be collected. The timing of the blood culture, these sets can be collected simultaneously or over a short period of time. Third is when this blood is collected, how is to be distributed. So 10 to 15 ml of blood should be inoculated into one aerobic bottle and one anaerobic bottle. Okay, so if 20 ml is collected, 10 ml goes to aerobic bottle and 10 ml goes to anaerobic bottle. If 30 ml is collected, then 15 ml in aerobic and 15 ml in anaerobic. But if less volume is received, then first 10 ml should go into aerobic and whatever is left should go into anaerobic blood culture bottle. Now, what should be the blood to broth ratio? There are many laboratories who are making their own blood culture bottle, the conventional blood culture bottle. In that case, as per the CLSI guidelines, the blood to broth ratio should be in between 1:5 to 1:10, depending the constituent of the blood culture bottle. There are certain ready-made blood culture bottles where they add certain proprietary items, because of which the blood broth ratio is even less than that. So if you're buying the ready-made blood culture bottle, always see the manufacturer instructions that how much blood volume should be added into that bottle. Now, why this ratio is important? Because there are certain inhibitory substances that are present in the blood that inhibit the growth of the bacteria. What are these inhibitory substances? These are complement, lysozymes, phagocytes, antibodies, or maybe antibiotics. If the patient is on antibiotic, these are the inhibitory substances for the growth of the bacteria. So when we use this dilution, they neutralize the effect of these inhibitory factors and help in the growth of the bacteria. So this dilution factor is extremely important. That is why you need to see the manufacturer instruction how much blood to be added. If it is overfilled, if the blood culture bottle is overfilled, then again it will not give you the good yield of the bacteria, because these inhibitory substances will not be diluted. And obviously the bottle should not be underfilled, because if the level of the bacteremia is too low, then you will fail to catch that bacteria. So that's why both the exact volume is important. Now, as per literature, which was published in VMMC in 2007, they justified the use of more than one blood culture set. As per that publication, they say if you take one blood culture set, the sensitivity of the blood culture is 73.1%. If you take two blood culture set, the sensitivity is 89.7% to detect the bloodstream infection. And if you take three blood culture set, the sensitivity is 98.3% to detect the bloodstream infection. I understand in the Indian scenario, it is difficult to obtain even one, forget about the blood culture set, even one blood culture with the adequate volume is difficult to get from our, in our setup. But we need to change that culture. So to begin with, first of all, we need to educate ourselves. We need to educate our phlebotomists, our clinicians, and slowly and gradually try to implement to get at least two blood culture sets, if not three. So to begin with, start with the set, at least two bottles should be received, and then move on to the two blood culture set. It really increases the sensitivity, the yield of the bacteria that can be isolated from the blood culture specimen. Now, a little bit about the pediatric blood culture bottle. Now, many think that the pediatric blood culture bottle contains some different constituents, some different ingredients that helps in better yield of the bacteria. It is not like that. Each uninoculated pediatric aerobic bottle contains a comparable medium, similar as the adult blood culture bottle. But where is the difference? But the volume of this pediatric blood culture bottle is 2/3 to 3/4 to that of its adult counterpart. So where we are changing the volume. So you can put less pediatric blood and maintain the blood broth ratio. So for pediatric patients with a suspected bloodstream infection, 2 to 3 blood culture sets should be obtained within a 24-hour period. In the child, it may not be possible to simultaneously, take two blood culture sets. In that case, within a 24-hour time, you can take another sample to complete the blood culture set. Now, minimum amount of blood, universally the standard volume is 4 ml, but minimum amount of the blood from pediatric patient is, we try to draw the minimum amount of the blood from the pediatric patient. Why? Because lower blood volume in pediatric patients, potentially requiring more frequent transfusion to replace blood depleted by specimen collection. That's why a pediatrician is always very apprehensive and he keeps sharing that I cannot give you more volume than this. Because in pediatric patients, it takes more time to replace that blood loss. It is difficult to perform any puncture in pediatric population, and we presume that high level of bacteria is there in the blood of the pediatric patient with bacteremia because their blood volume is low. Okay, so that is why we assume that there is already a high level of bacteremia. So even if we draw lesser volume of blood from the pediatric patient, it will give good yield. Most of the literature and publications and research are done on the adult blood culture bottles, adult blood culture volume. Very less is done on pediatric, but most of the publication was extrapolated from the adult population research analysis. Now, as per CLSI, they say that for the newborn infants and children, the blood volume drawn should be no more than 1% of the patient's total blood volume. So, pediatrician can customize as per the baby infant volume that how much blood he or she can withdraw from the patient, because they also need to give the blood for the other investigation also. So they are the best person to decide how much volume they can take from the pediatric population. However, one of the publications in the JCM, they have given a recommendation, you can say, based on their own research, that based on the weight, how much blood volume can be taken from the pediatric population if you want to go for the blood culture. Okay. Now, a little bit about the specimen collection. The generalized thing is the universal phenomena that should be followed everywhere is that the specimen for blood culture should be collected. Additional procedure must be performed to maximize pathogen detection and minimize the risk of contamination. These two phenomena shall be taken care of. When you collect the blood specimen for hematological profile or biochemical profile, there the risk of contamination is not that worrisome. But when the blood is collected for the blood culture, the procedure shall be performed in such a manner so that to maximize the pathogen detection and minimize the risk of contamination. When possible, the second principle that shall be followed is, when possible, specimens should be collected before antimicrobial agents are administered. If the patient is already on antimicrobial, just before the next dose, try to collect the sample during that time because we assume that the level of the antimicrobial agent in the blood of that patient is minimal at that time. Third principle that shall be followed is that the specimen for blood culture must be collected first before any additional tubes. The fourth is aerobic blood culture bottle shall be filled first, followed by the anaerobic bottle. So before collecting the blood, first of all, there is need of blood culture bottle preparation. Always, immediately before venipuncture is performed, the rubber septum on the blood culture bottle or evacuated tube shall always be disinfected with 70% isopropyl alcohol by rubbing the rubber septum with friction and then allowing it to dry. This step is important to reduce the contamination. The second step that shall be done is the skin disinfection. To minimize the risk of contaminating blood specimens with skin flora, the venipuncture site requires minimum 30-second friction scrub with an appropriate disinfection. It's up to you as per your setup. You can choose a disinfectant. It could be rubbing alcohol, 70% alcohol followed by tincture of iodine or povidone iodine. You can use iodophos, you can use chlorine peroxide, or you can use chlorhexidine gluconate. It is totally up to you, but the skin you should get rid of the skin flora. So it requires minimum 30-second friction scrub. In most cases, upper extremity venipuncture is recommended for collecting blood culture specimen. Whenever possible, a peripheral blood specimen is preferred to a blood specimen collected from a line. When multiple blood specimens are collected from a line, the blood for culture should always be drawn first, and none of the blood drawn from the line should be discarded, because there are certain literatures, there were earlier recommendations that the initial blood shall be discarded. As per the present current CLSI guideline, they say none of the blood drawn from the line should be discarded, but it should be used. So these are the steps to collect the blood culture when you are using needle and syringe. You need to train your phlebotomist, and to do the training assessment also. We should be aware of each and every every step. So the first step is the phlebotomist must prepare the blood collection kit. After that, confirm the patient identity and do not use and check the blood culture bottle. It should not be beyond their expiration date. And always check that up to which mark you are supposed to collect the blood in the blood culture bottle. The second step is prepare bottle for inoculation, that I have already mentioned, that the cap or the septum of the bottle, the outer covering of the bottle shall be scrubbed with 70% isopropyl alcohol or adequate disinfectant to allow contamination. The third step is to prepare the venipuncture site. The vein of the upper extremity is preferred, mainly the medial cervical vein. So apply the clean examination gloves. Sterile gloves are not necessary. Then clean the skin with appropriate disinfectant. For example, chlorhexidine and 70% alcohol or tincture iodine. Let it dry. The swab shall be applied in a circular motion and then let it dry. And after that, do not palpate. If you feel you would like to palpate, then use the sterile gloves and then only palpate. And after that, the fourth step, you do the venipuncture. To prevent the contaminating the puncture site, I repeat again, do not repalpate. Okay. Then the fifth step is to inoculate the blood culture bottle. So this is how you should inoculate. First the aerobic blood culture bottle and then the anaerobic blood culture bottle. The ready-made blood culture bottle has a vacuum inside, so automatically they take up adequate volume of the blood. In the conventional blood culture bottle, there is always a mark. So you need to inject the blood up to that mark. To maintain that blood-broth ratio is really, really important for a good yield of the bacteria. If you're using ring blood culture set, the steps are same. You need to prepare the blood collection cage. The bottle should be disinfected before inoculation. The preparation of the venipuncture site by adequate disinfectant. Then you do the venipuncture and do not repalpate after disinfecting the skin. And the fifth step is culture bottle inoculation. So this is how, with the help of the wing set, you do the blood culture inoculation. Same, first aerobic and then anaerobic and then any other additional test, whatever you want. So what is the recommendation of CLSI for taking blood samples for from short-term peripheral catheter? So as per CLSI, it says 2 peripheral blood culture sets should be obtained from the patient by venipuncture. Then the catheter should be removed aseptically and cultured by the semi-quantitative method. The blood culture result should be interpreted as follows. So this is about the peripheral catheter. Please remember, this is not about the central line, that will be covered by Dr. Manisha in the subsequent session. So if the patient is on peripheral catheter, then you need to take 2 peripheral blood culture sets and then remove the catheter aseptically and culture it also by semi-quantitative method, and the result should be interpreted as follows. If the result of the blood culture set is also positive and the result of the catheter segment is also positive, then interpret it as that the patient most likely to have catheter-related bloodstream infection. Okay, this could be the one possibility. Second possibility is that the blood culture set is positive, but the catheter segment is negative. In this scenario, if the blood culture set is showing the presence of organism of either Staphylococcus aureus or Candida species, then only you consider CRBSI. Otherwise, the results are inconclusive. The third possibility is blood culture set are negative, but the catheter culture is positive. In that case, interpret as colonization of the catheter and there is no bacteria. And the fourth possibility is that both of them are negative. Blood culture is also negative and catheter segment culture is also negative. In that case, here the CRBSI is unlikely. Now, what is the recommendation to collect the blood culture if the patient is on central venous catheter? Now, this will be covered. What are the criteria? How do you interpret? This will be covered by Dr. Manisha in the subsequent lecture. Here, I'll emphasize only on 3 points. One, at least 2 blood culture sets should be obtained from a patient with suspected central line associated bloodstream infection. Second, at least 1 set should be obtained from a peripheral venipuncture and labeled it properly, that it is from the peripheral venipuncture. At approximately the same time, the other set should be obtained aseptically from the catheter hub or through the venous access port septum and labeled as such. Okay, so if the patient is on central venous catheter, take 2 blood culture sets, 1 from the peripheral vein, 1 from the central vein. While taking from the central vein, clean the hub first, disinfect the hub first with 70% isopropyl alcohol, scrub it for 15 to 20 seconds and then only take the sample. And accordingly, you will interpret that will be covered in detail in the subsequent session. Now, once you collect the sample, the specimen labeling is very important. Okay, so you can make your own SOP in the labeling. What all things do you want? And accordingly, the specimen shall be labeled. At the same time, it is very important that from where the blood is taken, the collection site, it should be there on the label. Now, the ready-made bottle, the automated bottle that many of the labs are using, you need to train your staff that when they are putting the label on the bottle, this barcode shall not be hidden by this label because the machine gives its result or identify the bottle by reading this barcode. So the first picture shows the proper labeling of the blood culture bottle because you can see the barcode over here and the labeling on the other side. Whereas in all other bottles, the labeling is incorrect. It is placed on the barcode system and the machine is not able to read the bottle in this case. Now, the next is about the specimen transport. Once the blood is collected and inoculated into the blood culture specimen. As per the CLSI guideline, the specimen for blood culture should be transported to the laboratory at room temperature as soon as possible after collection, and it is recommended that it should not be delayed for more than 2 hours. It is not recommended that you keep the bottle at room temperature for more than 2 hours. It will decrease the yield of the bacteria. So it should be transported to the lab as early as possible. Blood culture or tubes should never be refrigerated because certain bacteria are temperature sensitive. Either they are inhibited or they are killed, and it gives false negative results. And third, there are certain setups where the blood culture is collected in the ward and they keep it over there at 35 degrees Celsius, thinking that it is at adequate temperature, but no, this practice will give a false negative result. As per the CLSI guideline, pre-incubation or delay of inoculated bottles at 35 degrees Celsius is associated with false negative cultures, especially if the bottles are incubated or delayed for more than 12 hours. These false negative results are likely caused by the organism reaching a stationary phase in the blood culture medium before the blood bottle is loaded onto the instrument. Thus, they fail to meet the threshold of growth detected by the instrument algorithm. If you are using the continuous blood culture monitoring system, if you are using the automated system, in that scenario, if the inoculated blood culture bottle is kept outside at 35 degrees Celsius, especially for more than 12 hours, then when you load that bottle into the instrument, the threshold of the organism is already in stationary phase and it doesn't reach to the threshold where the machine will detect it as positive and will give you the false negative result. Now, the last slide is on the specimen rejection criteria. You need to keep it in mind that because blood drawn for culture may be irreplaceable, it is a precious sample, so flexibility is warranted. Specimens should be processed even if they are suboptimal, but inform the clinician or the phlebotomist that there is the problem. However, blood culture specimens should always be rejected and another specimen should be collected if the blood culture bottle or tubes are incorrectly labeled or unlabeled, are broken or damaged or leaking, and contain clotted specimen. In these scenarios, you can reject the specimen. So these are the references from where I have prepared this lecture. Thanks for your time and attention. This lecture will be taken by Dr. Bhawna Sharma. Dr. Bhawna Sharma is currently working as Associate Professor at Bardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. She has done a senior residency from VMMC and Safdarjung Hospital, and she has worked at various other institutes like CLSI, Delhi and Faridabad. Currently, she is working in the anaerobic culture for more than a year, for more than 4 years, and she has around 22 publications. Now, I invite Dr. Bhawna Sharma to proceed to the next session. Over to Dr. Bhawna.
So, I'll be conducting this session with the role of anaerobic culture in cases of septicemia. So, as now all of you must have aware about the septicemia, what is that? Few things I wanted to cover with this my lecture. This anaerobic culture, anaerobic organism is, I believe, this is a very unserved, a bit of unserved area in the field of microbiology. But believe me, when I started 4 or 5 years back with this culture, I actually found so much of organisms. Actually, they are leading for a chronic cases in the infection of the septicemia, whatever other samples are coming to me. So my presentation is based on those things. So I'll be covering with this lecture the specific learning objective for this lecture are something brief about the anaerobes and its classification, prevalence of anaerobes in the cases of septicemia. What are the culture media we use it, and common culture techniques for anaerobic culture, side by side, the antibiotic sensitivity testing for the anaerobes, and yes, the emerging resistance in among the anaerobic organisms. So something brief about, I wanted to tell a brief few slides for what are anaerobes. We are actually considering the aerobic pathogens, the main causes of the septicemic infections. But anaerobes are also isolated, and I have quoted few recent and earlier days studies also where you can correlate. Yeah, they are also the findings where the a patient is given with the treatment of the aerobic pathogens, and they are showing the infection still, the fever, the symptoms are still there. Okay, so when should we suspect cases of anaerobic towards that, as patient is not well responding to the drugs given? See, the drugs used for anaerobic organism is the same one, but the course of treatment, the duration of treatment is quite longer in cases of anaerobic infections as they lead to the chronic infections. So coming to the main slide, something brief about the anaerobes and their infection, what type pattern. So anaerobic bacteria are part of normal flora, as all of us know, of the human skin and the mucous membrane. These conditions ranges from local abscesses to the life-threatening infection. I'm just giving you one example, very common example, daily we can get it. Some road traffic accidents come. If there is a RTI case comes to us, what first thing is come in my mind? Yes, the infection primarily is a polymicrobial infection. If the clinical presentation within 24 hours, patient presented with a case of gas gangrene and crepitation, or later on proceeded for a necrosis, color change, cold extremities, These pictures go towards the cases of anaerobic infection. So from local absence to life-threatening, because the treatment of the gas gangrene should be started with the antitoxin immediately to the patient. Otherwise, the infection leads to life-threatening to the patient. So anaerobic bacteria differ from aerobic. How come? How they are different from them? Only on the basis of oxygen requirement. Why? This oxygen is toxic for the anaerobic. Why they are toxic for the anaerobic organism? Because these pathogens don't have few enzymes. Those enzymes are present variantly in the cases of aerobic. Those enzymes were the catalase, superoxide dismutase, and peroxidase enzymes. These three main enzymes were present in the aerobic pathogens, but they are deficient in the anaerobic. So, by the action of organism, by the action of these oxygen over the organism, they got killed. So that's why due to action, they are the oxygen metabolizing enzymes that is deficient, and they cannot tolerate the oxygen, so they are categorized under the anaerobic organism. And they are fastidious also, and actually believe me, they are very difficult to get isolated from the polymicrobial samples. Usually anaerobes are present mostly polymicrobial things in blood infection, in septicemic cases. Yes, the aerobic organism are also running. Along with that, those the anaerobes also. So the diagnosis requires clinical suspicion. As I said, patient is not responding to the given treatment of the gram-negative and gram-positive aerobic pathogens, and the symptoms are still there, fever is still there. So the clinician or they should have a reason, yeah, we can go with the anaerobic blood culture also. Coming to these unphysiological conditions, so obligate anaerobes. So what do you mean by obligate? Means strict anaerobes. They are considered as important constituent of the many parts. What were the common areas of these anaerobes to be present? They are the oral cavity, female genital tract, colon, and their number exceeded the number of the facultative anaerobes. What is facultative? It means they can grow aerobically as well as the anaerobically also, with a magnitude of 10 to 10 to power 3. Means in these areas, the anaerobic numbers are that much enough as comparison to the aerobic. So the relevance of anaerobic bacteria as pathogen has been described basically from all anatomical areas, and these infections mainly categorized under two headings. What are those? First one is the exogenous or the classical infection that initially I have said about the gas gangrene, botulinum, lockjaw. These are Clostridium difficile, predominantly monomicrobial. They are toxic mediated diseases, and where the infection primary positive organism will be the spore forming gram positive rod, Clostridium genus. Whereas here we are talking with the septicemia. Usually the septicemia blood infection is proceeded in that way where the patient, all machinery, the vital machinery systems are getting shut down. It has started shutting down, and the all parameters related to liver or kidney or brain, they are getting deranged. So patient is moving towards the septicemic condition. Why this happens? Infections are mainly polymicrobial. I said it in blood. Obviously, the aerobic pathogen is also running, but anaerobic number is now more, so the patient is not responding to the given antibiotic for gram-positive or negative organism, and where the components of the normal bacterial microbiota are seen as a pathogen. I have covered references with these my slides also, so you can go and see that. So what are types? A very small introduction. So obligate, they are strict one. Examples were Bacteroides fragilis, Clostridium perfringens, Novii, Porphyromonas, Fusobacterium, etc. Aerotolerance means they can tolerate up to a certain level of oxygen above them. They can tolerate, so they are usually commensal, you can say, like Carmish or Clostridium histolyticum, so on. Microaerophilic, they can tolerate up to 21%. Here, they are not obligate, is not at all tolerating more than 0.5% of oxygen. Whereas aerotolerant, they can tolerate 5 to 10%. In microaerophilic, they can tolerate up to 21% of the oxygen. Example for microaerophilic is the Campylobacter jejuni. This is a classification medically important anaerobes, and these are the grand stain picture of the pathogen. So I have taken one of the organisms. They are the Streptococcus. This is the gram-positive cocci. You can see they are the gram-positive cocci. They are in the chain. The gram-negative cocci, that is the Vinonella. This is Vinonella species actually. They are gram-negative but bigger than the Streptococcus size. Gram-positive bacilli, among them we have the spore-forming organism, that is the Clostridium. You can see they are the gram-positive rods, long rods. Here you can see the spores also. Other gram-positive bacilli is the Actinomycete species. Very important chronic cases, meaning they are the beaded bacilli in a filamentous pattern. Gram-negative bacteria, they have the Bacteroides prevalens, very common organism to be isolated in the anaerobic blood culture bottle. They are gram-negative, long bacilli, whereas the Fusobacterium nucleatus, that is the main important species to be isolated from a cases of septicemia. So they are long, very long bacilli which are tapering in. Now, coming to main part, what is the prevalence of anaerobes in cases of septicemia? Patient is in septicemia. What is the general prevalence? Why should we go for the anaerobic infection? One reason behind that, patient is not actually responding to the antibiotics given to the patient. Why? Because this is a chronic cases. It takes longer duration of treatment for the anaerobic organism. So the percentage of positivity gradually you can say varies from the 0.5% to the 12%. Many studies are reporting these cases of that much. All cases of bacteremia or septicemia, this is the institutional study they have done depending upon the institution. Whereas this is important, I wanted to say bacteremia or septicemia, they are very high in secondary to the oral surgery, because in oral mucosa or in the abdominal surgery, the anaerobes are very important, 10 to the power 5 times more than the aerobic pathogen present there. These anaerobes play an important etiological role in many invasive infections and may be clinically significant pathogen in bloodstream infection and septicemia, despite of their low prevalence. So, the clinical characteristics of this anaerobic bloodstream infection do not differ from bacteremia or septicemia caused by aerobic pathogen, but due to longer generation time, anaerobes have 4 times longer generation time than the aerobic and rigorous growth requirement. It is very difficult to get the growth of the organism, which is the main pathogenic for a septicemic, chronic septicemic cases. And it takes longer to establish a etiological diagnosis. The anaerobic bacteremia or septicemia mainly affects adults with elderly patients more than 65. You can say and debilitated or high-risk patient developing these bacteremia or septicemia, whereas the prevalence of anaerobes in bloodstream infection in neonates and children are extremely rare. 0.5% up to with the children between 2 to 6 years of age. The Bacteroides prevalens group, why they are called group? Because 2 organisms are getting covered with this Bacteroides prevalens, Postgraduate species and the Streptococcus. That slide I have shown you, I will show you again that Ballabh slide. So Streptococcus, Bacteroides prevalens, mainly considered, and Clostridium mainly considered to be the cause of the anaerobic blood infection, whereas the Bacteroides prevalens group is found to be maximum of 65% cases in anaerobic bacteremia or septicemia. That I studied, these are the few reported 7-8 reports I have quoted here. You can see the year, like this is a study of this organism, septicemia due to organism, anaerobic organism. This study has been published in 1936. Before that, there are few studies also, followed by 1995 study with the anaerobic septicemia, and different studies like this 2009, then 2008. Like this, so many studies, permanent sepsis due to anaerobic bacterial infection in immunocompromised state, or the anaerobic sepsis due to MDR, Bacteroides prevalens infection, followed by like this anaerobic septicemia after transplant. They are the debilitating cases, they are the risk cases to get the anaerobic septicemia. They have been reported with this recent one of 2021 2022 must be having some publications. So next point I'm coming here, they are documented. It is proven in different parts of the world, the anaerobes getting isolated from the anaerobic blood culture bottle, anaerobic medium, and they are the pathogenic causes of the anaerobic septicemia. How? Now, next part of the session goes to what are the culture media to be used. In the previous session, you all must have been exposed, you must have been aware of the blood culture bottle. So anaerobic blood culture bottle is same like that of the conventional blood culture, that's the automated blood culture bottle. This is a Robertson cooked meat broth. It's a very common medium, liquid medium, and you can say the transport medium used for proper collection of the sample. Blood culture bottle, we will get the sample inside that blood culture bottle. That itself is sufficient and put inside the machine, the baptist machine, where by the process of CO2 generation, by the process of changes of metabolites, it beats up and we get the bottle positive of the patient, and we subculture the suspected organism, thinking of the suspected organism from that bottle. So what are the organisms quoted to be? The Clostridium, the Bacteroides, and Pepsis streptococcus. So few media's name I have just quoted. Here the anaerobic blood agar. This is the anaerobic blood agar showing the Clostridium perfringens, beta hemolysis over there. This is the selective medium for the Clostridium perfringens. That is the leading cause, main leading cause of the gas gangrene. This is the egg yolk agar. Bacteroides this is the Bacteroides bispulene agar, black color colony of this Bacteroides over the selective medium of the Bacteroides. Anaerobic phenyl ethyl alcohol agar. This is the blood agar. This is the selective medium for the gram-negative anaerobic organism. With this difficile also, you must all of be exposed that this is the antibiotic associated diarrhea which is causing, but yes, when there is the abdominal surgery, perforation, organism comes into the blood and they are in exceeded number of blood organism in the blood, leading to shutting off the all vitals. So this difficile could be also isolated in the cases of the septicemia. So this is a Robertson Cook withdrawal. Coming next slide to the anaerobic culture technique of the anaerobic culture. What are the common culture techniques we did? So first of all, in previous session, the one line must to be recorded in all of us mind that right sample at right time in right condition comes to the microbiology department to get isolated the right organism. Ideally, this sentence is looking very nice. Yeah, we can do. Practically, it is very difficult, to maintain this whole chain to follow the right from the getting collected to proceeding to the lab. It is a long time, but with this anaerobic, why I am focusing with the anaerobic? Number one, they are in a polymicrobial space, flowing with the mainly of the aerobes. So it is difficult to get aerobes to isolated from anaerobes to get isolated with the 3-4 of aerobes. Here the transport is extremely important when you have collected the blood culture in a blood culture bottle, or if you don't have a blood culture, FN blood culture, it is called for anaerobic blood culture. If this is FN blood culture is not available, you can take the blood of adult or pediatric in this Robertson Cook withdrawal itself and transfer. Why? Here this meat particles itself gives the anaerobic environment, because here the 15 glutathione are present, where when we put the blood over here, they utilize the organism utilizes these as a last electron receptor for them, and they survive. Side by side, what happens in the polymicrobial infection, the aerobic pathogens are not getting good amount of oxygen due to production of CO2 inside it. So they started decreasing in their number, and anaerobes getting increased or stabilizes their number. So the transfer of the organism, transfer of the bottle is extremely important to the machine or to the lab to get isolated. What are the culture techniques? Before this slide, I must show you, this is a candle jar. Definitely many labs are using this candle jar for the anaerobic pathogens or for the microaerophilic organism. Here simple mechanism of action is like that. We can make a candle to be burned inside the jar, and we put the flame and we close the lid. So gradually with this flame, it utilizes all the liberation of fluid is there, it utilizes all the oxygen, and considerably the oxygen amount is getting less and less inside this jar, and we can get the organism. Next, here is the anaerobic jar. I must say, this is the anaerobic jar. This is having shackles. Here, definitely, all lab is having these shackles. These packets are important. These envelopes contain sodium bicarbonate and sodium borohydrate. This is present inside that. Along with this hydrogen packet, water is getting added with this. Once this packet is opened, keeping this plate inside this jar, the CO2 getting liberated with oxygen. Whatever the remaining amount of oxygen present inside this, reacts with this hydrogen and produces water droplets after the outside of this chamber. So this is anaerobic indicator is also putting. So the color changes to the blue, showing my anaerobic condition has been maintained nicely. One advanced technology is that this is the anaerobic chamber, where you can see this is a cylinder and this is the glove boxes are there, where like the operation we put the hands inside. This chamber is totally cut off from the environmental O2 environmental surfaces, where we attaches this with the cylinder of CO2. Here the oxygen is reduced and removed, and it has been filled with the CO2 and the nitrogen. Nitrogen is an inert gas. This is a mixture of the cylinder. It should be replenished, and when it has been used, the date should be mentioned. Hand should be put inside this anaerobic block chamber, and all the procedure what you want to put it, you can do, and heat the plate, and you can put the jar, this jar, or one more jar I'm going to show you, to the incubator. So here we are cutting all of the oxygen to get exposed, to reduce the exposure of my organism to the pathogens, to the oxygen. This is a new technology. This is the enoxomat. This is a machine, small machine. The same thing, different lids you can appreciate. These lids to be attached with these plates. After CV, one catalyst to be put inside it. The lid changes the atmospheric pressure inside this chamber, removing the oxygen, filling this chamber with the CO2 and the nitrogen. The same way, but the process is fast. It is a digitalized process. Here is a touch screen monitor where you have to select for a 0% of oxygen, and the machine itself does its work, and you can keep it this chamber, this jar inside the incubator, and get the findings after 48 to 72 hours. Number 5 is this Macintosh Wildy's anaerobic jar. Common, same process of action. Keeping out of the oxygen, filling with the carbon dioxide and the nitrogen. This is quite, time-taking process. This enoxomat is its advanced form. Here is the gas pack system. This is a commercially available packet of gas pack is available, where you need not to put any type of catalyst in it. You just have to clear the packet, feed this jar with all of your plate. Cut this gas pack jar shacket, put it inside, and immediately close the jar and keep it inside the incubator. Here, palladium catalyst may be needed. Palladium catalyst, some jars need catalyst where the color changes to black, shows we have to remove the catalyst. Some jars don't need to get this palladium catalyst to be there, and put it inside the incubator, and you can get the isolate. Coming to the next slide, I'm just concluding a small part of what I have covered. So the organisms common would be for the anaerobic septicemia. What is there? They are the Clostridium, the Bacteroides vaginalis, and the different Bacteroides species. Last one is the SASP, antibiotic sensitivity testing for the anaerobes. The CLSI recommends the agar dilution and the broad dilution, micro dilution for the culture. It is, believe me, this is actually a troublesome process to make a broth and put the medium and do it. But CLSI is considering this is the ideal. But here I have put it to other studies. Many studies have been published where they have showed, they have used the gradient diffusion test. The commercially available included, they have the gradient diffusion E strips or the MIC evaluator strips. with the different companies are available, which can replenish with this broth micro dilution or the agar dilution system. So we can see the plate and we can put these yeasts. They are coming in the combination of the beta-lactam, lactamase also, and different all anaerobic, like aerobic antibiotics, the anaerobic drugs are also available. So we put it over there and we get the result within 24 hours, whereas for the this macro and micro broth dilution test, it is a troublesome, and this can be done for some epidemiological surveillance or some thesis work also. This is the advantages and disadvantages of the ASV testing, that agar dilution and what I tell, this is the first labor intensive, but MIC gradient, this is easy to use, precise MIC values obtained, convenient for testing, and so on. Lastly, I want to introduce few words about the emerging resistance among the anaerobes, which are causing the septicemia. Ideally, we all of us have a brain of mind that metronidazole is a very good, sufficient drug to be used for anaerobic organism getting killed. But I'm focusing here mainly on metronidazole resistance here due to this NIM gene presence, and due to haphazard or random or without any extensive surveillance use of metronidazole in the treatment of the septicemia cases. Many emerging diseases, many emerging organisms are there, varying from 1997 or before that also to 2021-22 cases, where the role of metronidazole resistance has been upcoming in the failure of the treatment for anaerobic septicemia. So the proper culture technique should be noted, should be done to follow what are the sensitivity, what organism getting isolated, and how we have to judiciously use it. This MTZ resistance is mainly seen with the gram-positive isolate, gram-negative isolate level. Other drugs are the same as of the aerobic pathogens, and so we have to judiciously using with these drugs for the treatment of the anaerobic septicemia cases. So the last is my references, what I have done, they are covered here. And thank you so much.
So next session is about the role of biomarker in sepsis. I'll invite Dr. Monika Matlani. She is currently working as Associate Professor in Vardhaman Mahavir Medical College. She has done her MBBS from Lady Harding Medical College and MD Microbiology from Maulana Azad Medical College. She has written a book titled Last Minute Revision Microbiology, consisting of 63 chapters, and she has over more than 28 publications. Now I invite Dr. Monika to take the next session on role of biomarker in sepsis. Dr. Monika.
Thank you, Dr. Shilpee, for giving me the opportunity to speak. So I'll be talking about the role of biomarkers in sepsis. So we've since morning we have had multiple sessions, and we all know that sepsis can occur suddenly and deteriorate rapidly, and the timely diagnosis is a key to success. But there is a lot of dilemma in the diagnosis of this. Am I audible?
Yes, ma'am, you are audible.
So there is a lot of diagnosis, dilemma in the diagnosis of.
Can you speak a little louder, ma'am? Actually, your voice is too low.
Okay. Is it fine now?
Yes, ma'am. Yes, ma'am.
Okay. So, so the diagnosis, there is a lot of dilemma in the diagnosis of sepsis, like how to do the early correct diagnosis, whether the sepsis is infectious or non-infectious, or if it is infectious cause of sepsis, whether it is bacterial or non-bacterial. Should I start the antibiotic therapy? What should be the course of the therapy? And what is the risk stratification of the patient? These are all the points which keep on hassling us constantly. Now, we've been talking about the criteria for sepsis, Apache score. We talked about SOFA score and Q-SOFA score. And in addition to these clinical scoring systems, we have a battery of tests for the sepsis screening, which includes total leukocyte count, platelet count, peripheral smear, ESR, blood sugar, LFT, KFT, X-ray chest, X-ray CT, CT chest, ECG, ECO, ABG analysis, and culture of the body fluids and the gram staining from the body fluids. And the gold standard for the confirmed diagnosis of sepsis is blood culture. But the problem with the blood culture is that it takes more than 24 hours to give the report. And if there is some organism growing, then it takes 48 hours to report the sensitivity of that organism. So what else can support us for the diagnosis and the prognostication of the sepsis? For that, we have biomarkers. So the biomarker is a quantifiable and measurable indicator of the biological status in normal and pathogenic processes. These biomarkers can have diagnostic uses. So they have a diagnostic use, as we have just discussed, whether the sepsis is due to infectious etiology or non-infectious etiology, whether it is fungal or bacterial. So in the diagnosis, they have a role in prognosis also for the risk stratification, to predict the outcome, to predict the complications in the particular patient. And they are also useful in the therapeutics, like whether to start the antibiotic or not, whether to de-escalate or escalate the antibiotic. And escalation and de-escalation of antibiotic is very, very important, as we want to counter the emergence of multi-drug resistant pathogens. That is very, very important. So there are various biomarkers which have been being used in the diagnostics, prognostics, and therapeutic usage. Around more than 100 biomarkers have been studied till now, and we see that in case of sepsis, the infected or affected organ, immune cells, vascular tissues, and neurons, all these kinds of cells release hundreds of biochemicals which can be used as biomarkers. So the common biomarkers which are being used in the laboratories currently are lactate, C-reactive protein, procalcitonin, and cytokines. So I'll be starting with the lactate. Why lactate? Because lactate has a correlation with Q-SOFA score and SOFA score. Both these scoring systems take blood pressure into account. That means the low blood pressure happens in case of sepsis. So if there is low blood pressure, obviously the tissue will have less oxygen delivery. If the tissue does not have oxygen, obviously there will be hypoxia and the tissue will undergo anaerobic metabolism, leading to lactate production. So hypoperfusion leads to increased amount of lactate in the body at that time. The cellular metabolic failure leads to increased lactate in the body, and the liver gets affected in sepsis. That is why the clearance of the lactate is also affected. So overall, the lactate concentration in the blood increases during sepsis. Now, we need to know what are the normal levels and what are the abnormal levels. So normally, the levels of lactate range from 0.5 to 1 millimole per liter. If the tissue is stressed, it can be increased, but it will be less than 2 millimole per liter. In case of lactic acidosis, which happens in case of sepsis or severe sepsis, the levels of lactate go up to 4 millimole or more than 4 millimole per liter. So more than 4 millimole per liter is significant lactate amount, which is indicator of sepsis. Now, lactate clearance is also predictor of prognosis. It is also used in the prediction whether what will be the mortality, what will be the chances of mortality. So if the lactate clearance, which is calculated by the formula lactate at the time of presentation minus lactate at 6 hours divided by lactate at the time of presentation, that is the formula for lactate clearance. So if within 6 hours the lactate clearance is decreased, percentage decreased, good percentage of lactate is decreased, that means the mortality chances will be less. So lactate clearance has to be demonstrated that it is clearing very fast from the body. If it is not clearing from the body, that means the mortality may be high. Now coming to the next biomarker, that is C-reactive protein. We all are very much aware about C-reactive protein because in the COVID times, CRP demand was very, very high. So the same CRP can be used in case of sepsis also. So it's an acute phase protein and it is synthesized in the liver. Our cytokines like IL-6, IL-1 and TNF-alpha stimulate the synthesis of C-reactive protein, and it binds to the bacterial polysaccharide. The level of CRP begins within 4 to 6 hours after the stimulus. It doubles every 8 hours and it peaks at 36 to 50 hours. So the levels of CRP rise very fast with the deterioration in the cell perfusion and increase in the bacterial circulation into the blood. I'll be talking about the levels of CRP along with the PCT because I have a comparative analysis of CRP and PCT. Both of them are very routinely used in most of our laboratories. So coming to procalcitonin, this is a peptide precursor of the hormone calcitonin, which is produced by the parafollicular cells of thyroid gland. So in normal situations also, calcitonin is released. The physiological PCT levels are 46 picogram per ml. However, if there is significant bacterial infection, the levels of PCT rise very fast. So 0.05 nanogram per ml to 2 nanogram per ml, the levels increase very fast. And within 2 hours, the peak comes. 2 hours, it starts increasing and the peak comes in 12 to 24 hours. So it is rising earlier than CRP. CRP was rising in 36 to 50 hours, whereas it is peaking in, the procalcitonin levels are peaking in 12 to 24 hours. So it's a good marker for severity and it has shown a sensitivity and specificity of 80%, nearly 80%. In the critically ill patients, PCT levels elevate in correlation with the severity of the bacterial infection. And the concentrations exceeding 0.5 nanogram per ml can be interpreted as abnormal. So it plays an important role for starting the antibiotic or escalating or de-escalating or changing the antibiotic. So it has been demonstrated by various researchers and it has been suggested by the various guidelines that if the PCT concentration is less than 0.5 microgram per ml, the antibiotics should be discouraged. And it should be strongly discouraged if the levels are less than 0.25 microgram per liter. The concentration, when it goes from more than 0.5 microgram per liter, the antibiotics usage is encouraged. You should start antibiotics only when the concentration of PCT goes beyond 0.5. And if the concentration is going more than 1 microgram per liter, then antibiotics should be strongly encouraged. The reverse applies for the de-escalation. So when the patient's PCT level decrease by more than 80% from the peak concentration, or the overall concentration of PCT goes beyond 0.5 microgram per liter, then the antibiotic should be stopped. If the decrease is less than 80% from the peak concentration and the concentration is still equal to or more than 0.5 microgram per liter, the antibiotic should be continued. If the increase in the concentration as compared to the peak concentration and the concentration is still more than 0.5 microgram per liter, then the antibiotic should be changed. So basically, PCT can guide us to start and to stop and to change the antibiotics. Now coming to a comparison of procalcitonin and C-reactive protein. So these are the normal values of PCT and CRP in the healthy people and in case of severe condition of septic shock. So CRP raises to more than 50 milligram per liter. It can go up to more than 50 milligram per liter. As such, more than 6 milligram or more than 10 milligram per liter, it is considered to be significant. Whereas in case of PCT, more than 10 is septic shock, and anywhere values more than 1 milligram per liter should be, microgram per liter should be considered significant. Now, if we compare PCT and CRP both, the CRP levels may further increase in the stages of sepsis, but they remain high for a long time. Whereas PCT rises in proportion of the severity of the sepsis, and it reaches its highest levels in case of septic shock. Another study which had done the comparison of various biomarkers, they demonstrated that PCT has got highest sensitivity, 88%, and specificity, that is 80%. The sensitivity of CRP was found to be 66% and specificity was still 80%, whereas lactate showed lower sensitivity as compared to PCT and CRP, that was 58.3, and specificity was found to be 88.1%. Pro-BNP was also studied by these patients, but we are not using Pro-BNP very commonly. Pro-BNP is bionatriuretic protein. Now, apart from PCT, CRP, and lactate, some of the cytokines have also been used for the sepsis mark as the sepsis marker. In fact, amongst them, again, we have talked about IL-6. Largely, we have used IL-6 in case of in COVID times. IL-6 have been used very widely, so that IL-6 can be used in case of sepsis also, but the concentration increase in the infection, but the activation time is short. But the sensitivity has been reported in neonatal sepsis, but usefulness in the adult diagnosis is not very well established. So a lot of work is going on IL-6, but in adults, the usefulness is still being studied. TNF-alpha is again in the study phases. No conclusive results have been obtained for TNF-alpha as yet, although knowing the physiology, we know that IL-6 and other cytokines raise, but how much do they correlate with the patient's clinical condition, that is still being studied. So another study who have done a comparison of PCT, CRP, cytokines, leukocyte, and temperature. So they have shown that cytokines have got high sensitivity, but the pitfall with the cytokines is that the variability is very high and the biostability is low, and the correlation with the severity of inflammation is less, which is good thing about, which is the plus point about the PCT, that it usually correlates with the severity. Leukocytes and temperature are simple and highly sensitive methods, but the specificity of these techniques is low. In fact, the CRP has got an advantage that it is not at all expensive. If you take the latex agglutination test of CRP, it can be done in the actual cost lies less than 10 rupees per test. So if you go expense wise, the CRP is the one which is cheapest test to perform, especially with the latex agglutination. But it does not give you the quantitative values. You can do semi-quantitative, but exact quantification is not possible with the CRP. Now, there are few new sepsis markers which are being studied. I will just, make you familiarized with the names, because nothing conclusive have been found about them, so we will not go into their details. But yes, they are in pipeline, and maybe we get more studies done, and they tell us about the usability of these new sepsis biomarkers. So pentraxin, it has been seen to be associated with severe sepsis and fatal disease in the emergency room patients with the suspected infection. Soluble CD14 subtype, it is commercially available by the name of PATH-FAST, and the generic name is Perceptin. Heparin binding protein, soluble receptor for advanced glycylation end products, SRAGE, and S-TREM, triggering receptor expressed on myeloid cells 1. These are few new sepsis biomarkers which are being studied, but the promising results and the guidelines have still to come about these usage of these new sepsis biomarkers. So the way forward for us is that for the stewardship, the 3Ds, 4Ds are very important for antibiotic stewardship: right drug dosage, de-escalation of the pathogen-directed therapy, right duration of the therapy. These Ds can be guided by biomarkers, and especially procalcitonin. However, it is very unlikely that a single biomarker will be sufficient to diagnose, prognosticate, and manage the sepsis. So a right combination of biomarkers will be required, and that right combination of the biomarkers we still have to work on, which will help us in diagnosing, prognosticating, and therapeutically being used in the patient. So that's all, and thank you very much.
Our next session is on surveillance of healthcare associated bloodstream infection. It will be taken by Dr. Manisha Jain. Dr. Manisha Jain is currently working as professor at Department of Microbiology, Govind, Ballabh Pant Institute of Postgraduate Medical Education and Research, New Delhi. She has done her undergraduation from Lady Hardinge Medical College and post-graduation in microbiology from Maulana Azad Medical College. She has done projects on various aspects of infectious diseases, especially drug resistance. She has been involved as principal investigator in multi-centric projects related to antimicrobial resistance. She has undergone training on antimicrobial research in October 2017 at Cleveland and La Jolla, USA, under the joint Indo-US Vaccine Action Program by NIAID USA and ICMR. She has over 30 research publications in various national and international journals. So I'll invite Dr. Manisha to begin the next session.
So today we would be talking on the surveillance of healthcare associated bloodstream infections. We've had a nice set of lectures on the sepsis, the current guidelines, and the sample collection and all. So to maybe the microbiological part, how do you want to surveillance, do the surveillance of healthcare associated bloodstream infections? Now, what do we understand by surveillance? Like, surveillance is a continuous systematic collection, analysis, and interpretation of data on specific health-related events. Dr. Shilpee, first slide. If yeah, thank you. So basically, surveillance should be, whatever surveillance we are doing is useless unless it is timely disseminated to the stakeholders who can really improve the outcome. So we need to take care of that we're able to, yeah. So how do we define a bloodstream infection? A primary bloodstream infection where there is no source, a secondary bloodstream infection where there is another source which is available, and LCBI is a thing which we call it as a lab confirmed bloodstream infection, and it has a separate designation as in the mucosal barrier injury type 1, 2, 3. We will not be delving into the details of those. So we'll stick to primary and secondary. So we have the CLSI surveillance, which utilizes the major event type, that is a bloodstream infection, and the specific event type would be a lab confirmed bloodstream infection. So that is the synonyms of the bloodstream infections. Now there are multiple HAI surveillance systems. The one that we are following is by the National Healthcare Safety Network, CDC. This is otherwise also the most widely accepted and used system worldwide. So we are following this NHSN system. Another is European Center system. So the types of surveillance that we can do is either continuous surveillance, where you have a lot of resource is required. So we need active and passive surveillance by infection control practitioners on a daily basis. Then we have a periodic prevalence surveys, which is a good substitute to the continuous surveillance. And it can be performed in a period as a single day or a week. Then alert based, if you have a specific condition like CLSI or an alert organism like CLSI due to Candida albicans, you're only looking for that kind of a surveillance. And a post-discharge surveillance, this is usually done for surgical site infection. It's not required for a CLSI. So what do we need for a surveillance? We need to know who are the population that we are going to do the surveillance. Here for CLSI, the denominator is all the susceptible population, which would include your inpatients, ICUs. In selecting the outcome or process for surveillance, you want to do a passive, active surveillance, periodic surveillance, continuous surveillance, using surveillance definitions. This also needs to be customized. You need to collect data daily, regularly, periodic, analyze it, apply the stratification, and report this surveillance information for the betterment of the patient by informing the stakeholders.
You can move the screen, Dr. Manisha, now.
I can share the screen?
Yeah, you can move. Okay, no, I am moving. Just a minute.
You can move.
I'm not able.
Can you move the screen?
No, I cannot move the screen, Doctor.
Okay.
Okay, I think I can. I don't know. Okay, the next slide, Dr. Shilpee. Right.
It is stuck somewhere. Okay.
Yes, yes. Okay, so if we have the framework, then we need to know what is the difference between the surveillance and diagnosis. See, the diagnosis is different and surveillance is different. We should not mix and match these terms. Diagnosis is for treatment of patients. Surveillance is a monitoring. So we need to define the criteria for surveillance and for diagnosis. Surveillance is publicly reportable. Diagnosis, you don't need to say. This is only for the current patient for that thing. So we don't need to change the terms interchangeably. And there will be situations where the patients would meet the criteria for CLSI. But if you want to define a surveillance criteria, surveillance wise, it will be CLSI. But if you want to see the stringent criteria diagnostically, it might not actually be a catheter related bloodstream infections. So we need to be very clear. So these are the definitions for CRBSI, or I would say this is the diagnostic definitions for CRBSI. When you need to define that same organism from semi-quantitative culture has been isolated from the catheter tip, probable if it is with or without the removal of catheter, and possible if it is in the absence of a lab confirmation of a BSI, that is only clinically if it is there. So we have different ITSA guidelines, CDC guidelines, and Public Health Agency of Canada guidelines who are defining these methods to diagnose the CRBSI. So the next slide would show you that when we have a catheter-related bloodstream infection, so there will be bacteremia, which we will see in the lab. We need to see whether the intravascular catheter is in place. There is clinical sign. There is no apparent source. So you need to have a proof that the catheter is the culprit before saying that this is catheter-related bloodstream infection for the purpose of diagnosis. Okay. So the burden of proof is there while you diagnose a CRBSI, which is not there in case of a surveillance. So as I said, growth of the same organism from catheter tip culture or two simultaneous blood culture samples, one from the catheter and one from the peripheral vein, where the catheterized sample is 3 times higher than the count is 3 times higher than the colony forming unit from a peripheral culture, or the differential time to positivity is 2 hours faster in a catheter culture. So this is to show or conclusively prove that there is catheter which is the culprit. Now for CRBSI, the lab confirmed bloodstream infection for surveillance definition. This is the surveillance. Those were the diagnostic definition where you need the proof. Here, we just need one criteria that the patient has a recognized pathogen from one or more blood culture, and the pathogen is cultured from the blood that is not related to an infection in another site. Okay, so only the isolation of a pathogen in the presence of a clinical symptom or the catheter was in place. That is enough to say that what we are talking about is surveillance positive for CRBSI, catheter-related bloodstream infection. There we don't need to prove it beyond doubt that catheter was the culprit. It is just that the catheter needs to be in place for more than 2 calendar days before the organism is isolated from the bloodstream infection. So we have various terms which are defined by the NHSN, surveillance terms, which will be useful for all the healthcare associated infections, including the CLSI. So we will be having some more exercise. So it will be good to get familiarized with these words like date of event, the date when the specific infection criteria occurs for the first time in the infection window period. So that was either the patient is positive for the blood culture or there is fever. That is a date of event. Then you have an infection window period which ranges from 3 days above to 3 days below the date of event. Present on admission is when on the day of admission the event is there. So includes the day of admission, 2 days before and the day after admission in the setting. Then repeat infection time frame is a 14-day infection time frame during which no infection of the same type are reported. That is a repeat infection time frame starting from the first day of the infection window period. And then we have a secondary bloodstream infection attribution period 14 to 17 days of period starting from the first day of infection window period, during which there should be no site which should have the same organism or same pathogen which should be isolated. Okay, so CLEP-C surveillance is valid from the day of insertion of central line till the next day of central line which is removed. So this is the denominator we will be using. CLEP-C is said when there are 2 calendar days before the patient is having fever or positive blood culture. But the surveillance starts from the day of insertion. All terminologies which I've already told you, date of event, infection window period are applicable. And now what do we call it as a central line? It is an intravascular catheter that terminates close to the heart or the great vessels. And devices which are not included are the arterial catheters, AV fistulas, grafts, peripheral IV lines, pacemaker wires. These are not included as a part of the CLEP-C surveillance. It is only the intravascular catheters that are terminating close to the great vessels. So we have 3 criteria which we need to know. Central line criteria, catheter line in place for more than 2 calendar days, or if removed, date of event is on the next day of removal. Symptoms, either of these symptoms if present is taken as a date of event, that is fever, chills, hypotension, apnea, bradycardia, anything that is there in the patient, these symptoms would be taken as a date of event. And culture is pathogen isolated in 1 or more blood culture, or if it is a commensal, that has to be from 2 or more cultures, or a known pathogen from 1 or more blood culture. And then secondary bloodstream infection will delve as we go in more detail. So just to conclude some examples. For example, patient has a central line inserted on June 1. On June 3, the central line is removed. And on June 4, the patient has a positive blood culture with Staph aureus. Do you call it as a CLEP-C? The answer is yes, because the central line was in place for more than 2 calendar days, June 1, 2, 3, and was in place the day before the event. The second is that if the patient was admitted in the facility on May 30th and on June 3 the central line is removed. On June 5 the patient again has a fever and 2 blood cultures are collected. On June 6 are positive for Staph epidermidis. So you see, June 3 the central line is removed. The patient is having fever 2 days after June 3. So this may be a healthcare associated bloodstream infection, but it's not a CLEP-C because the date of event did not occur on the day after the removal. That is June 3 or 4. So this is not a CLEP-C for surveillance purpose. Okay, so this is a case scenario 1. So you can see here there's a patient who's admitted on 24/9. There's a central line present itself on the 24/9. The fever is occurring on day 10. The patient is not having any other symptoms. So the date of event would become, day 10 would be the date of event. If I want to say the date of event is the presence of symptoms, so date of event would be day 10, 3rd October. Then the infection window would be 3 days before to 3 days after, that is day 7 to day 13 would be the infection window period. Then if you want to see the repeat infection time frame, it would be from the date of event for another 14 days where no other culture should be possible. So it will start from day 10 to another till 14 days. And the secondary bacterial attribution period would be from the first day of infection window period, that is 39 to 2610. It will be more clear. So next slide. So we had on 5/10, patient had a blood culture which showed Burkholderia. 5/10 only the urine showed E. coli. There were 2 different organisms. So the same organism is not growing. The patient is having fever. Central line is in place for more than 2 days. Yes. Pathogen identified from blood culture is not related to any other infection. Yes, because it is Burkholderia, urine may be have E. coli. Commensal grown, it's not applicable. So surveillance diagnosis would be CLEP-C. So we have already told you the date of event. The first day when we have fever is the date of event, that is day 10. The central line was in place. So the infection window period is day 7 to day 13. The secondary bacterial attribution, secondary bacteremia attribution period is from day first day of infection window period, that is 39 till 1610. And the repeat infection time frame would be from the first day of event, that is day 10 to 14 days. So yes, You can see here, this is what we've written. Till 1610 would be the repeat infection and the SBAP. And yes, the surveillance diagnosis for this case is CLEP-C. Now the second case scenario, the same thing. You have a central line which is in place from day 3, that is 26/9. The patient is having fever on day 10, and the blood culture was positive even earlier. Maybe we will the 29. The next slide will show you the 29. Okay, next slide. Okay, blood culture was taken on 29, which showed E. coli, and on 5/10 there was another blood sample which was taken which showed CLEP. So next slide. Okay, so the date of event here is 29/9. The fever though was there on the first day of fever was day 10, but the date of event, that is a positive blood culture, would be taken as a date of first event that is positive. Either a symptom or a blood culture would be taken as a date of event. So 29/9 would be date of event. The infection window period 3 days here and here, and the repeat infection time frame would be from the first date of event to 14 days. So that is your repeat infection time frame. So you can see here, the center line was in place. Yes, there was a pathogen E. coli which was isolated, and this will be a single episode 2 pathogen. In the repeat infection time frame, if you have another pathogen which is isolated, you call it as a single episode for the purpose of surveillance. Okay, so the diagnosis CLEP-C, single episode 2 pathogens, E. coli and CLEP. You do not call it as CLEP-2 CLEP-C episodes within the RIT. Okay, so this is the last case scenario that I'm going to discuss, day 3. Here, the patient is having on 4/10, the patient, okay, the central line was present. On 4/10, the patient is having fever. Here you can see, this is the first date of event, and the blood culture was drawn. The next slide. Next slide, please. Next slide. Yeah, thank you. So this was a blood which was, the blood culture was drawn on 2nd, which was sterile. 6/10, there was Klebsiella, and on 9/10 there was a urine sample which was there, which also showed Klebsiella here. So you see there are 2 pathogens isolated in between 3 days, 6 and 9/10. So what is our what is the date of event? Date of event is the date of event that was 4th here. So you had an infection window period which was 3 days before to 3 days after. There was a, from the first day you had a secondary bacterial attribution period, that is day 4 to 17 days. Here, the repeat infection time frame was not created because we had 2. So the next slide. Repeat infection time frame was not created here because we had 2 separate events in the second. On 9th, from urine also we had Klebsiella. So what will be the diagnosis? Central line is yes. Pathogen is isolated from 1 blood culture, yes. Okay, but the problem is that there was another specimen which grew Klebsiella, same as the blood sample. So it could be probably a secondary bloodstream infection. So this is a UTI with a secondary bloodstream infection, but for the purpose of surveillance, this is not CLEP-C. So this we need to be clear that within the RIT, there should be no other sample which is positive for the same pathogen. So there should be a written surveillance plan. I hope those scenarios have made it clear how to go about diagnosing the CLEP-C for the purpose of surveillance. There should be a written surveillance plan for the healthcare facility, including what are the definitions, how you want to collect the data, frequency, who is responsible for those surveillance activities. And it should support a system that can identify the risk factors for infection and other adverse events. Risk reduction should be there, and you should be able to monitor the effect of interventions. So the CRBSI surveillance would facilitate identification of the catheter-related complications, and most importantly, timely interventions would be there. And the infection surveillance program should include the following components: that you should track the catheter placement, which starts from the day that you have placed the catheter. You monitor the CRBSI rates by the surveillance definitions that are given. And then you definitely, another important step is intervene, evaluate the rates, monitor it, and communicate it to the clinicians for a better monitoring of the patient. Thank you.